Breathing during sleep is supposed to be automatic, but for millions of people, this essential rhythm is repeatedly shattered. Sleep apnea is characterized by frequent pauses in respiration that fragment the sleep cycle and deprive the body of oxygen. Look closely at what happens during one of these episodes. Deep into the sleep cycle, the rhythmic rise and fall of the chest suddenly comes to a dead stop. The autonomic nervous system is plunged into silent, sudden distress. Most of the time, this happens because of a mechanical blockage. In obstructive sleep apnea, the tissues in the throat collapse. The body is still actively struggling to pull air into the lungs, but the physical airway is closed. This cross-section compares the two conditions. In central sleep apnea, the physical airway remains completely open. The pause in breathing happens because the brain stops sending the signal to breathe. Because there is no signal, there is no respiratory effort whatsoever. The diaphragm and chest muscles are entirely paralyzed in these moments. The brain has simply forgotten to initiate the breath. This means that surgeries or devices designed to prop open a collapsing airway are useless here. Fixing central sleep apnea requires addressing a breakdown in the body's neurological control center. To confirm this breakdown, doctors rely on polysomnography, a comprehensive sleep study used to map a patient's sleep architecture. On the surface, the two types of apnea look remarkably similar. A sleep study will show both conditions causing a sharp drop in airflow, rapidly followed by a severe reduction in blood oxygen. Clinicians track the severity of these events using the apnea-hypopnea index, which measures exactly how many times these breathing pauses occur per hour of sleep. This mock polysomnography readout shows exactly how clinicians spot the difference. To differentiate a mechanical obstruction from a neurological failure, the sleep technician looks at two specific bands, the thoracic and abdominal effort channels. In an obstructive event, the airflow line drops to zero, but the effort bands show frantic, jagged waveforms. The chest and abdomen are desperately heaving against a blocked throat. Now look at a central event. The airflow drops to zero, and the thoracic and abdominal bands flatline right alongside it. The body isn't struggling, it's doing nothing at all. Distinguishing this synchronized flatline allows clinicians to differentiate hypoxia caused by a blockage from a failure in the brainstem. Without this data, a clinician might try to treat a plumbing problem when the real issue lies in the patient's chemical sensors. The rhythm of our lungs is commanded by the brainstem. It operates continuously in the background, firing signals that expand the chest wall. You might assume that a lack of oxygen triggers the brainstem to pull in a fresh breath. In reality, the primary chemical driver for respiration is the accumulation of carbon dioxide. This diagram outlines a continuous feedback loop connecting the lungs and brainstem. Specialized chemoreceptors in the brainstem continuously sample the blood flowing past them, monitoring every tiny fluctuation in CO2 concentration. They are programmed to look for a very specific baseline concentration, known as the apneic threshold. The body must maintain enough CO2 in the blood to stay above this critical line. As long as the carbon dioxide levels hover safely above the threshold, the brainstem keeps firing and normal respiration continues. Healthy sleep relies entirely on the precise, uninterrupted calibration of this continuous chemical feedback loop. Central sleep apnea occurs when this control system destabilizes. The brainstem's chemoreceptors become overly sensitive, overreacting to minute shifts in blood chemistry. This graph plots carbon dioxide concentration over time, with the horizontal line representing the apneic threshold. The failure cycle usually begins with a brief period of hyperventilation. The patient breathes a little too deeply, which rapidly clears too much carbon dioxide from the bloodstream. As the lungs overperform, the CO2 concentration plunges beneath the apneic threshold. The moment that line is crossed, the brainstem senses there is not enough CO2. It responds by instantly shutting off the respiratory signal. The breathing halts completely. With the lungs idle, the body continues its metabolic work. Carbon dioxide begins to slowly accumulate in the blood again, steadily climbing back toward the threshold. Once CO2 levels cross the threshold, the brain sends a delayed, oversized signal to resume respiration. This sudden jolt forces the patient to take a series of deep, rapid breaths. That overbreathing immediately crashes the CO2 levels back below the threshold. locking the system into a continuous, self-perpetuating loop. Throughout the night, this relentless cycle of hyperventilation and paralysis jolts the nervous system awake repeatedly, subjecting the heart and blood vessels to severe physiological stress. This kind of severe loop instability rarely happens on its own. It is almost always a secondary symptom, driven by an underlying systemic disease or the introduction of exogenous chemicals. One of the most critical clinical presentations of this is Cheyne-Stokes respiration, a highly recognizable breathing pattern intrinsically linked to severe congestive heart failure. This dual-panel view illustrates the mechanism of delayed circulation time. A failing heart pumps blood so sluggishly that it takes much longer for the newly oxygenated blood in the lungs to physically travel up to the brainstem. This extreme lag time scrambles the chemical feedback loop. The result is the classic Cheyne-Stokes airflow pattern, a distinct cyclic crescendo and decrescendo of breathing effort. The patient's breaths become deeper and faster, then gradually shallower, inevitably terminating in a prolonged central apnea as the brainstem struggles to interpret outdated CO2 data. Beyond cardiac issues, central sleep apnea is also frequently induced by medications, most notably prescription opioids. While a failing heart delays the signal, opioids attack the brainstem directly. These drugs alter the loop by actively suppressing the baseline respiratory drive, dulling its sensitivity to rising carbon dioxide until the impulse to breathe disappears entirely. If a patient is suffering from daytime fatigue and shattered sleep architecture, fixing it requires looking past the lungs to identify which specific external system, cardiac or chemical, is hijacking the respiratory loop. Leaving central sleep apnea untreated accelerates a dangerous physical decline. The continuous oxygen desaturation and the relentless sympathetic arousals put immense strain on the body, directly worsening existing cardiovascular disease. The first unbending rule of treatment is to address the root cause. Before applying specialized breathing devices, clinicians must work to optimize cardiac output in heart failure patients or safely taper down offending opioid prescriptions. Complicating matters is a phenomenon known as treatment-emergent central sleep apnea. Sometimes, placing a patient on standard CPAP to fix a collapsed airway inadvertently unmasks an underlying instability in their central loop, replacing obstructed events with central ones. This clinical decision tree illustrates the treatment options. When positive airway pressure is absolutely necessary, standard CPAP often isn't enough. Instead, doctors utilize BiPAP machines equipped with a backup respiratory rate, which mechanically force a breath if a central pause lasts too long. For more complex cases, the decision tree moves to advanced therapy, specifically adaptive servoventilation, or ASV. This device tracks the patient's breathing, breath by breath, dynamically adjusting air pressure in real time to artificially stabilize the volatile CO2 loop. However, this therapy poses a direct threat to patients with severe heart failure and a low ejection fraction. In these cases, the machine's dynamic pressure can further reduce the heart's ability to circulate blood, significantly increasing the risk of mortality. Central sleep apnea is an invisible failure of biological control. It reminds us that every breath we take is part of a fragile chemical equation. Restoring that rhythm means stabilizing the feedback loop, carefully, precisely, and without overwhelming a compromised cardiovascular system.